So that's who we are. And today we just want to describe a little bit about the context of implementing a number of child evidence-based practices within the PEI services in LA County. And Lillian is going to talk about that context, and then Lauren is going to, she's my co-PI on this NIH-funded study, she's going to introduce the context of the 4-KEEP study, and then I'll be presenting some preliminary findings on disparities.
So the study focuses on Los Angeles County, which is the largest county-operated Department of Mental Health in the United States. If you want to have a sense of the size of that, all the states in blue have smaller populations than Los Angeles County. The Department of Mental Health has 78 directly operated sites and 288 contract agencies. On average, we serve more than 250,000 individuals of all ages, both ethnically diverse and urban and rural. Skip that one. Okay, so in the context of this study, I want to give a sense of the urgency and the implementation process that occurred. MHSA, the Prop 63 was passed in 2004. The Prevention and Early Intervention Guidelines were released in 2007, and LA County engaged in an intensive planning process that involved 10,000 individuals throughout the county. And in 2009, our plan was approved by the state. The plan was for 52 evidence-based practices, promising practices, community-defined practices, and pilot programs. We had a well-defined program for rolling out all of these programs. However, approximately 6 months later, the state had a budget crisis, and we learned that there was going to be a shortfall for the LA County Department of approximately between $32 and $42 million, which would have resulted in a devastating cut in service delivery for all of our provider agencies in fiscal year 10-11. So agencies were expected to lose 50 to perhaps 100% of their funding allocation under county general funds, which threatened their viability. A number of them might have had to close their doors. So in the context of this crisis, and to prevent the closure of these community-based agencies, the department decided to intensify the implementation of prevention and early intervention practices and allow agencies to utilize these funds, if they so decided to do so, to leverage the Mental Health Services Act funds. So this occurred in January of 2010, and the cuts would take effect in July 2010. So in the context of this also, the county facilitated the rapid launch of a number of evidence-based practices to address the range of youth and mental health problems. So the department also supported the implementation of these evidence-based practices through training, consultation, implementation guidelines, training and outcome measures. In the midst of all of this transformation, if you get the sense of urgency, we have a large 250,000 of people that we're serving. What happened is, I recall in fall of 2009, I was at a conference where the title of one of the programs was titled, "Never Implement More Than One Evidence-Based Practice at a Time." And consequently, the following year, I was co-presenting with somebody else, and the title of our workshop was, "How to Simultaneously Implement 25 Plus Evidence-Based Practices Without Stressing the System." The study focuses on, it's a long study, 5-year study, and it focuses on those early stages of how we focused on certain practices for children and what the results have been in there in terms of culture, perspective. This is evidence-based, a lot of resistance to that, as you may know. It required outcomes, it required training. It's a whole new paradigm shift for the department. So with that, I will let Lauren talk to you about the study.
So thank you, Lillian, for giving a an overview of the context of this study. So Anna and I came at this as mental health services researchers, child psychologists, and implementation scientists. And from the kind of rapidly growing area of implementation science, we were really interested in this context of system-driven implementation of multiple evidence-based practices. This is a growingly common context of EBP implementation, where there is this implementation rather than driven by an intervention developer, driven by a system and includes multiple EBPs. So we applied for NIMH funding and received NIMH funding starting in 2014 to conduct a neutral observational study examining how 6 of those EBPs in child mental health that Lillian mentioned that were initially supported by DMH, meaning that they organized and facilitated and funded the training, the provider trainings in a very rapid time period, to look at how those 6 EBPs spread and that they continue to be used over time. So we are interested in characterizing that EBP sustainment up to 8 years after the initial implementation, and then really look at what were the variables and factors that lead to the greater spread and continued use of these practices. We also applied for and received a supplement to our NIMH funding to look at disparities, and particularly to look at the extent to which there were racial and ethnic disparities in the EBP implementation outcomes and the process. So, as I mentioned, we started the study in 2014, and we have the opportunity to characterize implementation of these 6 initial practices over the course of 8 years post-initial implementation. And this is a big study in which we're characterizing implementation in a number of different ways. We're using mixed methods, so both quantitative and qualitative methods to characterize the sustainment. These areas in blue really reflect us looking at sustainment from the system perspective, so large-scale system perspective. We'll focus on that today. But the areas in green are really we're honing in an in-depth way of these practices in 26 agencies that are delivering these practices, where we're collecting semi-structured interviews, collecting audio recordings of sessions. So we're looking at the practices as they're being delivered in an in-depth way. But we'll focus on the larger scale focus today. These data are from administrative claims data, and we're not going to get into the details. I'll just highlight that in the first 5 years, for these 6 of the 52 practices that were being implemented, 87,000 children were impacted by these services. So just to, again, kind of highlight the scale of this initiative within the county. We're going to be focusing today on some preliminary data that were collected via therapist survey. We have lots of different data, as I mentioned, but we're interested in therapist perspectives and their reporting of their practice for these six practices. I'll just highlight, we had almost 800 therapists respond to our online survey, and they're generally represented by the workforce. I'll highlight that they're racially and ethnically diverse, with 43% of them self-reporting being Latino, 11% API, and 7% African American. I think that something that's also important is that 57% of these therapists report delivering psychotherapy in a language other than English. So just to give you a sense of who these therapists are. So one of the contributions that we think is an important contribution of our study is how do we measure the integrity that therapists deliver these practices when we're not looking at just one practice, as the research typically does, where we're focused on detailed examination of fidelity to highly specified practice elements. Well, we have multiple practices that target multiple presenting problems. And so we're really focused on this concept of EBP concordant care. And what we are measuring in our ECA assessment, or EBP concordant care assessment, is assessing the extent to which a therapist delivering reports or is observed to deliver individual psychotherapeutic strategies within a session that are considered to be essential for a given EBP target. So the target being conduct problems, anxiety, trauma, or depression, or those are the four that we're looking at. We have multiple versions of our ECA assessment, and part of our aims are to actually develop this. But in our therapist self-report version, we have an inventory of 34 different strategies that a therapist could use in a given session. And they rate the extent that they used these strategies either in a session or over a 2-month period of psychotherapy delivery. And so those we're focused on kind of a 2-month period. And we're focused really on, we wanted a very pragmatic assessment, and it wasn't, so we weren't focused on any specific practice, but really what were the essential strategies for a given care target. So with that, and we're happy to provide more information about the development of the ECA offline, but for the sake of time, I'm going to turn it over to Anna, and she'll talk about some of our preliminary data related to the ECA.
Thanks, Lauren. So for the purposes of this talk, we did try to address the question of whether or not there were racial ethnic differences, client racial ethnic differences in EBP concordant care as reported by therapists delivering those practices. And apologies for not doing a terrible job aggregating across groups. As we presented earlier, the system is primarily serving Latino and Hispanic children and families, so you'll see that the ends are really representative of that. So we mostly are serving Hispanic Latino families, and these are the therapist reports of EBP concordant care for trauma practices and for conduct problem related practices. And what we're finding is with our relatively small samples of other groups, there are no significant racial ethnic differences by client race ethnicity in therapist reports of being able to deliver those practices with intensity. We also wanted to look at some process issues. So, following up on some of the talks that we've already heard about, we all know that these evidence-based practices, with some exceptions, have been developed in research settings with client populations that really, in many ways, don't resemble the families and children that are served in our county mental health system in terms of clinical profiles of severity, levels of adversity and disadvantage, and of course, cultural and racial ethnic differences. So one thing that we wanted to look at was not just reports of EBP concordant care, but also therapists' perspectives on encountering barriers to delivering EBPs in their community settings. So we looked at therapist reports of these barriers. And this is from our survey data where we really found that there were kind of 2 clusters of types of barriers that therapists were reporting. One was a set of behaviors that seemed to indicate disengagement of the client from maybe the content of the interventions or the strategies of the interventions. So these were things like therapists feeling that clients were avoiding participating in some aspect of the therapy. We called those things disengaged client barriers. And then other barriers really had to do with clients speaking up about some difficulty or difficulties that the clients were having in relation to learning or understanding or liking the EBPs. So we called those expressed client barriers. And you can see here just how often therapists were reporting these different types of barriers, perceiving these barriers happening with their clients. So then we looked at, were there differences by therapist perspective in reporting these barriers with clients from different racial ethnic backgrounds. When it came to the expressed client barriers, there was not a statistically significant difference between groups, but there was for these disengaged client behaviors. So actually, in this case, the Hispanic or Latino clients and families, therapists were reporting encountering fewer of these disengaged behaviors with Latino clients, and more with the group that were combining into other ethnic minority. So this would include African American and Asian Pacific Islander families for the most part. Okay. And then we wanted to look at how these client characteristics, service setting characteristics, therapist characteristics all predicted therapist reports of the intensity or robustness of delivery of EBP concordant care. And so we did sort of a multi-level model here. And next is just a summary of factors that we found were associated with higher therapist reports of EBP concordant care. And we did this for the trauma practices as well as the conduct practices for which we had enough data. So perhaps not surprisingly, when therapists liked the practice, so either the conduct or the trauma EBP, when they felt it was appropriate for their setting, easy to use, feasible, they reported a greater intensity of use of evidence-based concordant care. When they were trained for trauma practices, if they were trained in fewer EBPs, they reported more robust delivery of EBP. Latino therapists reported more EBP concordant care for those trauma practices. And for conduct, also therapists treating younger children reported more intense delivery of those conduct EBPs. Our thoughts, the engagement findings are very, very interesting to us because, of course, we thought what we were measuring were things that might get in the way of therapists delivering EBPs. So these were things that we thought had to do with, obstacles that the therapist had to overcome in order to engage the family in an EBP. We found really the opposite. We found that our community therapists that we were studying, when they reported that these obstacles were coming in and presenting in session, they seemed maybe to double down and really report more robust delivery of the essential strategies of EBPs. So this deserves much more attention. This is all therapist report. We are going to be looking at our session observations to see if we can replicate this with observational methods. But I think it's a very encouraging sign that community therapists are finding ways to align their practice with EBPs and also to respond to what the clients are bringing into session as well. So we're very intrigued to learn how exactly they're doing that. I'll skip to conclusions and just say at this point we have little to no evidence of at least therapist-reported differences in EBP implementation outcomes and very few differences in process so far. But these conclusions are limited by small numbers of non-Hispanic clients in our sample right now. Observational data, I think we also really want to pair with this to examine again in a different way potential disparities or differences in implementation by independent observers. Therapists are frequently reporting encountering barriers to EBP delivery, yet when this occurs, they also report increased intensity of EBP concordant care. We really want to understand how it is that they're doing that. I think we can learn a lot from community therapists who can help us generate this practice-based evidence about how to deliver these practices in community settings. And I just want to note that these are therapists in DMH-funded settings who are routinely seeing ethnic minority, low-income families. They can really yield a lot of knowledge and practice-based evidence about how to sustain EDP concordant care with the disadvantaged populations that we most want to help.